Good morning everyone. Myself Dr. Pratik Raval. Today we are going to discuss about various embolization techniques and their clinical implications. So in today's lecture we'll learn what is the principle of this therapy, what are the common clinical indications, what are various embolic agents that are available commercially, what are various techniques and how they are used actually in a clinical situation, and then certain complications which are peculiar to the embolization. So let's begin with the introduction part. What is embolization therapy? Embolization is basically intentional closure of a vessel, that is artery or vein, and this therapy is also useful in the targeted delivery of therapeutic agents as in the cancer chemotherapy. The main advantage of this technique is that it provides a conservative approach, means less invasiveness, reduce morbidity and mortality, shorten hospital stay and improved recovery time, and overall a positive impact in healthcare system, that is beneficial cost effective ratio. One of the most common indication for embolization therapy is bleeding, whether it is traumatic or non-traumatic, like upper GI bleeding or lower GI bleeding, hemoptysis, etc. Cancer chemotherapy is also one of the indication for this therapy, wherein we deliver the chemotherapeutic agents directly into the vessel supplying the tumor, thereby reducing the systemic side effect of the chemotherapeutic agents and improved concentration in the tumor itself. Sometimes this therapy is also used for preoperative devascularization. Certain tumors like nasopharyngeal angiofibroma are very vascular in nature, and these tumors can cause significant amount of bleeding during surgery. Hence, it is very helpful to devascularize them, to reduce their vascularity with the embolization therapy before undertaking patient for the surgery. Congenital or acquired vascular malformation and aneurysm are also a common indication. And then treatment of certain lesions like uterine myomas, benign conditions, other benign conditions of the uterus, uterine AV malformation are also commonly treated with this modality. So let us see what are various commercially available embolizing agent. If you see historically, the blood clot which was derived from the patient's own body was the first used embolization agent. It is obviously easily available and quick to obtain, biocompatible, and but the main problem with this blood clot is that body's natural fibrinolytic mechanism eventually kicks in, and sooner or later recanalization occurs. So the effect is not very long lasting. The next agents that were developed were the facial strips, which are derived from fascia lata, dura mater, etc., particularly for the neurointervention. Silk threads have also been used historically. But modern embolic agents can be classified either temporary agents or permanent agents. Temporary agents include gel form, collagen, thrombin, and there are many permanent agents including particles, coils, liquid, glues, and other vascular plugs and other devices. We will briefly discuss them one by one. So gelatin form or gel form, it has been used for many years. It is a biological substance that is derived from the skin gelatin. It is available in gelatin sheets as well as powder form, which consists of 40 to 60 micron particles. It can be used in various ways, like gelatin sheets can be cut into small pieces, 1 to 2 mm pieces, and then diluted with the contrast and then injected as pledgets. Or alternatively, powder can be made into slurry, as we can see in the lower panel, with the help of 3-way stopcock, and then can be injected. The gel form particles aggregate on hydration into larger particles, and thereby they causes mechanical obstruction of the vessel, slowing the blood flow and causing thrombus formation. It is a temporary occlusing agent, allows for recanalization within few weeks. The main advantage of this gel form is that the temporary nature. In some cases we do not need to permanently occlude the vessel. We need recanalization within few weeks, like cases of hemoptysis or trauma. It is obviously very cheap, and clinical experience is extensive with this material. The main disadvantage is that it can sometimes cause infection because of trapped air bubbles, and gel form powder can cause distal ischemia because the size is very small. Another particles are PVA particles. They are made from the PVA foam sheets that is vacuum dried and rasped into particles. These particles are then filtered through various increasing size of sieves, and they are available from 100 micron to 11 micron sizes. These particles are very irregular in shape, which promotes prompt aggregation. The various shapes are oblong, oval, irregular, and they are also angulated with small fragments once they are suspended in the contrast. They act by lodging into the small vessels. They adhere to the vessel, causes stagnation of the blood flow. Subsequently, they induce inflammatory reaction in the vessel, causes focal angionecrosis, and thereby neointimal hyperplasia and eventually fibrosis of the vessel. These particles are biocompatible, and there is lot of clinical experience. The main disadvantage of this particle is their tendency to aggregate. Because of their irregular size and various shape in the suspension, they can rapidly aggregate, and because of this they can occlude the vessel more proximally than originally planned. Sometimes this catheter gets clumped inside the catheter, causing the occlusion of the catheter itself, and then one may need to remove the entire catheter assembly out of the body, flush the catheter, and then start the procedure all over again. PVA particles can also accumulate sometimes in the catheter hub and can theoretically cause non-target embolization when the catheter is flushed in other vascular bed. Trisaccharyl gelatin microspheres are another particle commercially available as embospheres. These particles range in the size from 40 micron up to the 1200 micron. These are available as pre-packed 20 ml pre-filled syringe which contains 2 ml of sphere. They differ from PVA particle in that these are uniformly shaped and perfectly spherical particles. They are hydrophilic that are precisely calibrated by their size, and they are made from an acrylic polymer that is impregnated and embedded with porcelain gelatin. Particle accumulation in the catheter hub, particle aggregation, fragmentation, catheter occlusion, which are commonly seen with PVA particles, are usually uncommon with these TAGM particles because of their uniform shape. The main disadvantage of this particle is that they can easily get sedimented, and therefore there is constant need to agitate the saline. They are composed of porcelain gelatin which can cause allergic reaction in some patients, and finally careful attention is required while sizing the particle because they can penetrate more deeply compared to the PVA particle. Because of their spherical size, they can even cross the vessels which are smaller than their actual size, and hence they can cause distal ischemia. Coils are very commonly used agents. Jain Turco first described their use way back in 1975. The original coil that was used was a simple 038 guide wire which was curled and then injected through the catheter. Coils are permanent embolic agents. They come in various size and shape. They are typically used for occlusion of the large vessel, and they provide vessel occlusion akin to a surgical ligation. Coils act by occluding the vessel. They provide a thrombogenic surface over which clot formation occurs, subsequently causing vessel damage. Thrombus starts forming within less than 5 minutes after the deployment, and later on they induce a chronic inflammatory response in the vessel, and subsequent neointimal hyperplasia and fibrosis of the vessel occurs. The main problem with that with these coils is that they depend on the body's thrombus forming mechanism. So patients who are coagulopathic, such as patients with thrombocytopenia, patients with platelet dysfunction and abnormal clotting factors, in such patients the thrombus formation may be delayed or and thereby the effectiveness of the coil is reduced in such cases. The main disadvantage of the coils includes occlusion of the non-target vessel. Coil migration can result in catastrophic events like pulmonary embolism, stroke and myocardial infarction, particularly while treating a large AV malformation which has a very high flow. Vessel dissection, perforation, vessel rupture can also occur. Infection and allergy reactions, although these are very uncommon, have also been reported. Colonization of the coils with microorganism can occur at the time of coil insertion as well as after the coil insertion in the setting of bacteremia. These coils are generally made of steel or platinum. They come in various sizes ranging from 008 to 052 inches, and the length available are 1 to 300 millimeter, and the diameter also ranges from 1 to 27 mm. So vast variety of size and shape available. The shapes include J shape, C shape, helical structure, conical structure, tornado like structure, complex 3D structure. So they are available in a plethora of size and shape. The coils can also be fibered, means small fibers are attached over the coil surface to increase their thrombogenicity, like Dacron material, nylon fibers, polyester, etc. To deploy these coils, standard angiographic catheters are used for 035 and 038 steel coils. And sometimes if the vessel is very small, which hinders the catheter entry into the vessel, these coils are used with microcatheter, and for these microcatheters, small microcoils which ranges from size 012 to 018 inches are also available. The coil should be sized 20 to 30% larger than the vessel size to prevent the distal embolization. The main principle of coil embolization is the complete cross-sectional occlusion of the vessel. And in general, dense packing of the vessel is recommended to achieve complete embolization. And for these, various techniques are available. In scaffold technique, we initially deploy a larger coil with a high radial force that provides as a scaffold over which subsequently we can inject small coils. Another technique which is anchor technique, in which the coil is anchored in a small distal branch, and then the catheter is pulled back slightly, and then the remaining of the coil is densely packed in the proximal vessel. Various methods of coil delivery includes simple pushing, injecting the coil, and commercially available detachment systems are also there. Pushable coils, they are most commonly used coils. A special guide wire is with a bulbous tip is used to physically push the coil through the catheter to the intended location. The main disadvantage of this coil is that once we have positioned this coil, they cannot be repositioned, and sometimes they can become trapped at this catheter curves, and if they are incompatible with the catheter, they can permanently block the catheter, and the entire catheter has to be removed, and the coils are permanently lost in the catheter. Certain precautions needs to be taken while using pushable coils, like the guide wire should not be advanced far beyond once the coil is deployed, because it can cause inadvertent distal embolization of the coil. And the main technical problem with this coil is that while pushing the coils, the catheter frequently comes out of the vessel, and thereby resulting in proximal embolization rather than intended location. So these things need to be kept in mind. Injectable coils are nothing but standard pushable coils that can tolerate the injection with a small syringe. To use this method, one has to ensure a proper and secure placement of the catheter in the vessel to be injected. Vigorous injection can sometimes result in catheter backing out and non-target embolization of the coil. Soft coils like 035 and 038 coils can also be delivered via the injection technique, but mainly this technique is used with small coils like 018 and 014 coils with the help of microcatheter. Liquid coils are deployed by forceful injection of contrast through the catheter after loading the coils into the catheter. These coils are extremely soft, non-fibered, and it comes in the diameter from 008 to 016 inches. They are made of metal, but the liquid coils can be delivered across the tight bands and tortuosity of the vessels. They come with a pre-loaded introducer. The coils are loaded into the microcatheter with the help of 1 ml syringe, and then another large 3 ml syringe is used to gradually push the catheter up the coils up the catheter. The main advantage of these liquid coils is their ability to accommodate to the tortuous anatomy and ability to flow to a target which is far distal to the catheter location. And these coils are very optimal for treating tortuous vessels. Detachable coils. In these coils, the coils are attached to a wire, and then subsequently once the position, the desirable position is achieved, these coils are subsequently detached from the wire. Various detachment mechanisms include mechanical detachment, electrolytic detachment, and hydrostatic detachment. They come in variety of 3D and 2D shapes. So mechanical detachment system includes interlocking and screw release mechanism. The interlocking mechanism uses small metal beads or hinges at the proximal coil tip and at the end of the wire. And with the screw release mechanism, the coil is attached to the wire by clockwise rotation, and hence to release the coil from the wire, we have to rotate the wire in a clockwise direction, just like we release the ASD, VSD and PDA devices. In electrolytic mechanism, electrical current is used to detach the coil at the welding point. The platinum coil is welded to a platinum tungsten alloy, and it has a highly successful deployment rate. The main advantage of these electric mechanism is that we can reposition the coil, we can change the coil configuration if we find that the location or the configuration of the coil is not desirable. Even we can completely remove the coil before the detachment. This detachment also avoids motion while deploying the coil. The main disadvantage is that these coils are relatively expensive, they require expertise, and an elaborate setup is required while delivering. The technical problems that can be encountered with the with this electrolytic mechanism is that coil can get prematurely detached even without supplying the current. Proximal end of the coil can slip back inside the microcatheter, and then we encounter difficulty to deliver the coil into the vessel. Delivery catheter can also get melt because of the heat generated because of current. The hydrostatic mechanism uses the balloon technology. A platinum microcoil is attached at the end of a micro delivery tube. The micro delivery tube has a small micro balloon attached at the tip, and to release this coil, the micro balloon is inflated up to 700 psi with an indeflator. The main disadvantage is that sometimes there is a motion during the deployment of the coil, and the optimal position may not be achieved. Hydrogel coils are nothing but the platinum coils that are coated with an expandable polymer, and this polymer gets expanded once it comes in contact with the blood, and the size of coil increases from 0.14 to 0.27 inches, and thereby it provides a large volume of occlusion. Hydrogel is basically a liquid mixture that contains a monomer cross-linker and a polymerization initiator. The hydrogel is physiologically stable, and the main advantage is that it does not depend on the thrombus formation. It provides a greater volume of occlusion than the regular coil, and it is not affected by the body's fibrinolytic mechanism. The main disadvantage is that it can sometimes block the catheter. Another devices which are available for embolization is detachable sac. These sacs are made up of nylon which are attached to a sac catheter. The coils are initially injected in this catheter sac, and once the desirable position is achieved, this sac is detached from the catheter and the catheter is then removed. The advantage of this device is that we can reposition the sac, we can even remove the coil from the sac, and the entire sac can also be pulled out from the catheter. Detachable balloons, they pretty much act in same way as the detachable sacs. These balloons are made up of latex and silicone, and they are particularly suitable for large vessel occlusion and large AV fistulas like cavernous carotid fistula, pulmonary AV malformation. Their advantage is that they can be repositioned easily if the desired position is not achieved. The main disadvantage of the balloon include the risk of balloon rupture, balloon deflation, migration of the balloon, and premature detachment. Vascular implants or vascular plugs are rapidly gaining popularity nowadays. These are relatively new devices. The first device in this category includes Implication 1 device, which is basically a thick disc which is made up of a nitinol, and the size ranges from 4 to 16 mm, which is suitable for occlusion of large vessels. The second device in this series is an Implication 2 device, and this device includes two additional disc, thin disc at the either end of a central thick disc. The advantage of this Implication 2 device is that it provides a greater cross sectional area. The size ranges from 3 to 22 millimeter in diameter, and the length available are 16 to 18 mm. These devices should be oversized by 30 to 50% of the vessel size. They are relatively expensive, but sometimes they can save the cost because a single vascular plug may occlude the vessel, while to occlude the same size vessel one may require multiple coils. So they may actually reduce the cost. The main disadvantage of the vascular plugs is that they has to be delivered in a relatively straight segment of the vessel and a non-tapered vessel. These devices does not cause instantaneous thrombosis and sometimes can cause significant amount of hemolysis through persistence of flow through this device. They are non-fibered and they rely on patient's ability to form the thrombus, and hence patients with coagulopathy are not suited for these devices. Then we have certain liquid agents like N-butyl 2-cyanoacrylate, commercially available as a Trufil, which was approved by the FDA in 2000. This glue is supplied as 1 gram tube of NBCA, 10 ml of ethiodized oil and 1 gram of tantalum powder, which are then mixed together immediately prior to the use. The NBCA is supplied as a free monomer which is clear and free flowing. When this NBCA is exposed to anionic environment such as blood or water, the monomer starts getting polymerized and it forms a permanent glue. Ethiodol is used as a vehicle agent and it also retards the polymerization, premature polymerization. Tantalum powder provides radio opacity and also retards the polymerization. When NBCA comes in contact with blood, the polymerization immediately occurs. The polymerization rate can be altered by varyingly mixing the NBCA with ethiodol. Immediately after the glue injection, the catheter tip has to be pulled, catheter has to be retracted because the catheter, this glue can entrap the catheter in the vessel. NBCA makes the permanent cast of the vessel independent of the patient's thrombotic mechanism. And then it causes an acute inflammatory reaction in the vessel wall, which ultimately leads to chronic inflammation and fibrosis. The main disadvantage of NBCA is that it requires a substantial amount of expertise and experience. The catheter can sometimes become entrapped in the glue. Polymerization can sometimes spread distally or proximally and causes non-target embolization. and as part of this procedure the catheter position has to be abandoned. That means the catheter needs to be pulled out immediately after the deployment. Ethylene vinyl alcohol copolymer it is a copolymer of ethylene vinyl alcohol prepared with dimethyl sulfoxide as solvent. On contact with blood, the DMSO diffuses away, which allows the polymerization of EVOH and forms a permanent cast of the vessel. Onyx, which is a commercial name, is indicated for the treatment of cerebral aneurysm. It comes packaged with a separate vial of DMSO, and the special DMSO compatible catheter and syringes must be used while using this agent. Once the catheter is placed in the desired position, the catheter is flushed with DMSO and then to inhibit the in catheter onyx polymerization. Once the desired position is achieved, the desired catheter position is achieved, the onyx is delivered through the catheter under fluoroscopy guidance. The advantage over NBCA is that this is non-adhesive and allows temporary suspension of embolization, and one can also proceed with further angiography during the procedure itself if deemed necessary. The disadvantage includes the need for DMSO compatible catheters and series. The DMSO is also a toxic material, and rapid injection can cause vasospasm and vascular necrosis. The onyx is also not very safe, and the maximum allowable dose is 600 milligram per kg. Absolute alcohol is also used since long. It causes tissue infarction by causing protein denaturation, promoting acute inflammation and acute thrombosis. It use is generally limited to cases when the risk of non-target embolization is low, such as kidney. It is also commonly used for alcohol septal ablation in patients with hypertrophic cardiomyopathy. It is generally used with flow control using balloon which are inflated either in the artery or venous portion, and in some cases coils are also used to slow the flow of the alcohol. The main disadvantage is that this is not a very controlled device, and the diffusion of alcohol in other vascular bed can cause serious necrosis in the organ. So let us move to various embolization techniques and their clinical application. The various agents are used by proximal embolization, sac packing method. A sandwich technique is also available. Sometimes we need to place a stent, basically a covered stent, that is stent graft to occlude the bleeder, and percutaneous approach is mainly used when the endovascular approach is not feasible or it fails. So proximal embolization is mainly recommended in cases where there is multifocal injury and when we found a contrast blush on CT angiogram, but the bleeder is not clearly evident on catheter angiography. In such cases, proximal embolization technique is used. Let us see some example. One common example where this method is used is splenic trauma. Splenic trauma can pose the risk for acute splenic rupture, infarction and abscess formation, and hence it is important to coil the splenic artery. The splenic artery is usually coiled with usually with platinum coils or endovascular plug to spare the origin of the dorsal pancreatic artery and pancreatic and great pancreatic artery to maintain the collateral flow. Basically here we do not want to permanently occlude this splenic blood supply. We just need to slow down the splenic perfusion so that the splenic viability is also maintained and the risk of splenic rupture as well as massive hemorrhage is also reduced. This mechanism can also be used in patients with hypersplenism to increase the WBC and platelet count. Blunt liver trauma is also another clinical scenario where this technique can be used. Most of the time the liver trauma the bleeding is from the venous sides, but sometimes the arterial lesion can also cause bleeding in blunt liver trauma. These patients are usually hemodynamically stable, and in these patients endovascular approach is recommended. Obviously, if the patient is hemodynamically unstable, open surgical technique is always recommended. This can be performed through permanent and distal embolization if we can see a clear-cut bleeder on catheter angiography. But if the bleeder is not clearly available, the temporary embolization can be achieved with injection of gel foam after the origin of, as a shower embolization after the origin of gastroduodenal artery into the common hepatic artery. Renal artery embolization is frequently needed because renal pseudoaneurysm and AV malformation are common after renal trauma, and iatrogenic injury is also common with percutaneous nephrostomy. In this example, we can see on renal angiogram that after a nephrostomy, the patient has developed renal pseudoaneurysm as well as AV malformation, AV fistula. And in the right panel, we can see after coil placement, the pseudoaneurysm, the flow to the pseudoaneurysm as well as AV fistula is permanently occluded. Sac packing is another technique which is particularly suitable for a pseudoaneurysm and aneurysm that has got a very narrow neck, and when it is important to preserve the distal flow. This technique can be used with variety of techniques like balloon assisted sac packing, bare metal assisted sac packing, and percutaneous sac packing. In this example, a patient had a pseudoaneurysm in the distal splenic artery after trauma. In the lower panel, we can see multiple coils that are packed in the pseudoaneurysm. And the DSA subsequently showed the distal circulation into the spleen is preserved, and the aneurysmal sac is completely excluded from the circulation. The sandwich technique. The sandwich technique implicates embolization of both the afferent as well as efferent component of the vessel to completely exclude the vessel from the circulation. This is particularly useful when there is collateral blood flow and the blood from the collaterals can flow back into the lesion and restart the bleeding. The back door, which is called the afferent artery, is usually closed first, followed by the afferent artery. In this example, we can see a pseudoaneurysm in the profunda femoris artery after a trauma, and the white arrow shows the distal as well as proximal coil placement, thereby completely excluding that small vessel which was causing bleeding. So let us see an example of this technique. This was a 50-year-old male chronic alcoholic presented with obstructive jaundice and melena. USG abdomen showed hematoma which compressed the second part of the duodenum as well as common bile duct. His hemoglobin was 7 gram on presentation. On this selective angiogram with the help of microcatheter, we can clearly see a pseudoaneurysm which is arising from the gastroduodenal artery. On the right panel, we can see a small coil which is delivered through the microcatheter with the help of saline which is injected into the catheter. So this is basically a pushing technique of the microcoil. And in the lower right panel, we can see the coil is deployed distal to the aneurysm. So this is basically a sandwich technique, and subsequently the proximal vessel was also occluded using a larger coil. And then patient underwent CBD stenting with a double pigtail biliary stent to provide a biliary drainage. However, 20 days later he again presented with lower GI bleed, and repeat angiography showed increase in the size of the pseudoaneurysm. His hemoglobin further dropped to 4 gram per deciliter. We again performed an angiogram and it shows that there was some persistent flow through the pseudoaneurysm. And we suspected that it was because the patient was having jaundice, pancreatitis, he was also coagulopathic, and because of this the thrombus formation was not adequate, and hence there was persistent bleeding from the pseudoaneurysm. So we went ahead with additional packing with the coils, and in this technique we can see the coils being pushed with the help of a guide wire. There was also additional branch which was giving blood supply to the pseudoaneurysm, which was also closed. In the right upper panel we can see a small breeder, the anchor technique which we discussed, whereby we anchored the coil in a small vessel and then the coil was subsequently packed into the proximal vessel. However, despite coil packing, the flow to the pseudoaneurysm was not completely obliterated, and we had to use PVA particle also to achieve complete hemostasis in this case. Stent graft placement. This is particularly suitable when the neck of the pseudoaneurysm is wide. When the neck is very wide, the sac packing method is not suitable because of the risk of migration of the coil or the glue material in the main vessel. The main advantage of stent graft is that it completely excludes the pseudoaneurysm from the circulation, and at the same time preserving the distal flow to the organ. The percutaneous approach is used when the endovascular technique is failed, or sometimes when the aneurysm is not approachable by the endovascular route. In this technique, the pseudoaneurysm is localized with the help of ultrasound and CT guided, and once the position is confirmed, thrombin, glue or sometimes coils are injected percutaneously. One common example is thrombin injection in femoral pseudoaneurysm, which are very common after percutaneous coronary interventions. So various complication of the embolization therapy includes the excess site complication like pain, bleeding, hematoma, pseudoaneurysm formation, retroperitoneal hemorrhage, etc. The main risk with the embolization is the inadvertent distal embolization and infarction in the non-target locations. Continued bleeding, as we saw in our case, can sometimes occur because of the collateral blood flow. Post-embolization syndrome, which is commonly seen after within 72 hours of the procedure, it is associated with fever, nausea, abdominal pain, and usually seen with embolization in a solid organs like uterus and kidney. It is usually a self-limiting illness, and the treatment is usually symptomatic with analgesics and IV fluid. So to conclude, embolic agents are rapidly available in the market, and their use is nowadays increasing very commonly, particularly by the interventional radiologist. There are various commercially available agents, and their mechanism of action, their modality of delivery needs to be understood for their correct use. So thank you for your time.